hardware. Can we have the discussion slide, please? And any questions from the audience? Can I just ask you about that case? Have you noted with the banding of the RVAD outflow graft of the hardware to use it as a RVAD? I presume you can actually do that for patients only requiring a single right ventricular support rather than just BiVAD. And then secondly, have you noticed any increase in hemolysis, background hemolysis after banding of the RVAD outflow?
So let me answer at first for the second question. We did not see increased hemolysis at all. We didn't see embolic complication or something else. But it's a first experience. The pump is in just for 3 weeks, and this is just the beginning results. We use it only for biventricular support, not yet for only right ventricular support. With the banding, we make the banding in the operation room, and it works very well, no problem.
And can you explain to us the decision-making process of why you decided to do that for those 2 patients rather than use other conventional BiVAD that's available or total artificial heart?
The problem is that there is no good biventricular device available for long-term support. When you look for the cardiorest pump, everybody knows the cardiorest, after 1 year, the danger of membrane defect increase, and the patient one day, you can transplant him, otherwise he will die on the device. Maybe the pump pumps 2 years, after this time the membrane can be defect. When you look to the Bernhardt X-Core pump, another device for biventricular support, we have still the problem of infection and not of very high quality of life at home. We had a patient, he was more than 4 years on biventricular X-Core pump, but it's not so good quality of life, and still they have the infection risk. So we need a long-term biventricular support, and the only device can be a non-pulsatile implantable pump. I think the hardware gives a chance that it's a step forward for that.
George.
I was really interested in using this device as a BiVAD. The question is, that's my personal opinion on that, the device is not made for that. Definitely not. And I'm personally not very convinced it's going to work out on a long period. Anyways, this is not the reason why I'm asking. The reason is what you're going to do in case the patient shows any improvement of his right ventricular function. Do you think that you can first wean the patient, which might be possible, but can you take out the device in a way that you don't completely corrupt right ventricular function once again? Because, you made a large hole on it, on the ventricular wall, and right ventricular function mainly stays with the left-sided function from the lateral wall. So, what's your opinion on that?
I don't know what will happen if they will recover from the right heart function. But when we have more pulsatility on the right ventricle, maybe we let the pump inside. It's not necessary to explant it. When we cannot stop the pump, we have a regurgitation to the side of the right ventricle. We should explant it. I don't know what will happen in the future. I think personally we should stay it in. Let it in and pump.
Well,
but we will see it in the future. I don't know, like you know it.
I guess it's early days yet. You implanted these patients in the last couple of months. It will be interesting to hear the follow-up on these patients.
We will do that.
Let's say you, Francois from Ghent, you have a 3-year-old with a cardiomyopathy, end-stage failure, and he's probably not going to recover. What would you put in then?
How old he is?
3 years old.
3 years old. And what about the right ventricular function? It's the X-Core pump. It's good for the child. The X-Core child pump. And what about the right ventricular function?
Let's say it's bad as well.
And the kidney function and organ function?
It's still good.
I think the Berlin Heart X-Core left ventricular support may be a good opinion. I think still the X-Core pump for child is the best pump.
And if you have a, myocarditis and he might recover, what would you put in then?
Still we had a lot of patients could be weaned from the X-Core pump without any problems.
But with an apical cannula?
Also with apical cannula.
Okay, thank you.
Can you elaborate a little bit on von Willebrand factor deficiency in patients with a continuous flow pump?
Yeah, it's a lot of discussion about that, a lot of publications about that. So everybody knows the HeartMate 2 needs less anticoagulation. There's a lot of discussion if the von Willebrand factor is the reason for that. Nobody knows exactly if it's only the von Willebrand factor. We will see that. In our experience, the patient on HeartMate 2 needs less anticoagulation. We are doing that. We have an INR 2.0 to 2.5. Or an APTT for 50 to 55 seconds. It works very well. It's good, a good device. But I think the future examination with other non-pulsatile devices will see if it's only a problem from the HeartMate 2 or also from the hardware or the pumps. We don't know that. Nobody knows at the moment. We should look for that in the future.
Can I move to the question about, you mentioned left thoracotomy for patients who've had previous cardiac surgery. Some centers have moved away from that approach of doing the outflow graft to the descending aorta because of concerns about aortic root thrombosis. I'm aware that Jarvik, the controller, does fluctuate the pump speed, but what about the other devices? Have you had problems, and are you worried about aortic root thrombosis in those patients?
Yeah, I heard from Texas teams they are concerned about ascending aorta with potential thrombotic formations. We don't have this problems in our center, but we are looking also that the pump has, or the flow is still a little bit pulsatility, so that the aortic valve is opening. And we have
so do you actually specifically look at these patients with echo and set the pump speed on the lower side to ensure that the aortic valve is opening?
We're looking, especially when the patient goes well and it's an outpatient, we are looking that the aortic valve is opening, and we are looking also through echocardiographic examination.
Yeah, because a pulse-tau blood pressure doesn't necessarily mean that the aortic valve is opening, does it?
Sorry?
A pulse-tau waveform on the arterial trace doesn't necessarily mean that the aortic valve is opening.
Yeah, that's correct. And additionally, on intensive care units, it makes not a big importance. I think it's make importance for the long-term support, that you have a more pulsatility flow in this kind of patient.
Mm-hmm. So let's have a look at the questions that we have here on the slide. You've mentioned using ECMO as a bridge to decision in very sick patients. What's the sort of period that you would support a patient on ECMO before making a decision?
So we prefer in our center to not let the patient too long time on ECMO. We prefer when the patient has problem in the operating room, is a post-cardiotomy failure, heart failure, to implant immediately X-core cannula and to put on a Levitronics pump. We prefer in patients which is a candidate for an assist device to implant very early the pumps, also for problems for coagulation disorder. Mostly we have patients coming from other centers on ECMO, and the following day we make the decision if the device should be implanted.
So 24 hours?
24 hours, yeah.
Okay. Next question is about gastrointestinal bleeding. Have you seen that? Have you seen a higher instance of that in patients with continuous flow devices?
Sorry, have you seen?
Gastrointestinal bleeding.
Yeah, we have seen that. And in our centers, still the standard is to give patients on all devices Coumadin and aspirin in low dosage, depending on platelet aggregation tests. But in case of some bleeding complication, nose bleeding, gastrointestinal bleeding, we stop the aspirin dosage immediately. We let the patient on coumadin only, and then we have no more problems with that. My personal opinion is don't give aspirin on patient on non-pulsatile device. But I think that is my opinion, my personal opinion. That we will see in the future if that's the correct way. I think coumadin only is enough for this patient.
May I ask a question for this? It's evident right now, at least, unfortunately, you're completely wrong. There's not many publications around on von Willebrand's factor deficiency because everybody's talking about, but nobody is publishing. I don't know why. But as a matter of fact, at least, from the data we have, and that's more or less personal communication, a lot of patients go into this acquired von Willebrand's syndrome when they're on specific rotary pumps. The question is, and this was always the big issue, how to counteract. Because it's well known that a lot of patients who have that sort of acquired von Willebrand's disease bleed and others don't, although all of them, have this diminished multimeres. The question is, you said, well, you reduce the aspirin or you take it away. Don't you think, it would be smart to go for von Willebrand's factor, applying that because it's available, We've done it in one patient, although I have to say, this patient was not bleeding in gastrointestinal. He was just a very strong epistaxis, and we figured, he's got that kind of acquired von Willebrand's disease, and we were applying von Willebrand's factor, and it stopped bleeding. Although, we do not have evidence, that this was the case, but it was just a hypothesis. We were following that, and more or less, at least from the symptoms side, it improved. But maybe it would be smart to take this into consideration and follow that.
Is it not easier to stop the platelet anti-aggregation therapy?
Yes, but that doesn't change the situation that you have a lot of monomers instead of multimers, and that doesn't change your acquired von Willebrand syndrome state. That's it.
We shouldn't forget the ACE syndrome, involves also patients with the severe aortic stenosis. They face the same problem, with von Willebrand deficiency, and they have a higher risk for bleeding. In the post-op, there was a paper, in the New England Journal of Medicine a couple of years ago.
Well, that's absolutely correct, but it has been proven right now, and I think, this is common knowledge, that you don't only go for this breakdown of multimers into monomers, and therefore go into this von Willebrand's acquired disease. You have to have angiodysplasias as well in the gastrointestinal region, and then they start to bleed. So it's not only, and this is probably an explanation why all of the patients, have that breakdown of the multimers, but just a small number is bleeding. And I think, this could be a hypothesis. It's not proven yet.
That's correct, and also it's probably affecting more elderly patients rather than younger patients.
One more question I'd like to ask you. I think we hear the vast experience that Berlin has had with ventricular assist devices and Bettenhausen likewise, but a lot of other centers are doing much smaller numbers, so they don't have the luxury of having a whole spectrum of devices on the shelf. So going back to the original question or the topic of this talk, I noticed that you've got a range of rotary blood pumps, and of course, for most of us, the vast majority of patients will require a single pump as an LVAD. So how do you make a decision of which particular rotary blood pump you use? Do you think there's a difference between them?
For the different rotary blood pumps, I think this is mostly a personal, sympathetic question, what kind of rotary blood pump you prefer. So every rotary blood pump has advantages and disadvantages, and you should be comfortable with a rotary blood pump. You have the hardware, it's a good pump, the HeartMate 2 is also a good device, it needs less anticoagulation, everybody knows that. When you put in the in-core pump, it has been implanted more than 500 times worldwide, it's also a good pump, you need a little bit more anticoagulation. But I think the market is big, the Dura Heart has not a big number of implants, but it's a good pump for long-term support, but it's a little bit bigger, you need a bigger patient. I think you should feel comfortable with a rotary blood pump. That is the most important thing.
And going back to the question there, do you think the ability to perform the implantation through a left thoracotomy without using cardiopulmonary bypass can play a role or not?
Yeah, so in case we implant the Jarvik, we don't use the cardiopulmonary bypass. In other patients, we use the cardiopulmonary bypass. So I think this plays not a big role.
Okay. Thank you very much indeed. We'll draw this half of the session to a close. We'll have a coffee break, and then we will come back at 20 minutes to 11.